Good evening, everybody, and welcome to the Arthroscopy Insights today. We are very grateful and thankful to you for curating your precious Sunday for this shoulder webinar. We have some really top-end speakers. So, good evening from India, good morning to Brazil, and good afternoon to UK. We have speakers. We have our lead, who's Parag Sancheti, who will follow me and introduce the whole concept of Arthroscopy Insights, followed by Dr. Gopinathan from Kerala, then Dr. Amit Modi from Leicester, UK, and then we have myself, followed by Dr. Sujit Jos to talk on arthroscopic GT fixation, and then John will talk on arthroscopic AC joint reconstruction, followed by the final talk by Dr. Sergio Rowinski from Sao Paulo, who would talk about a very interesting type 5 AC joint dislocation, which we rarely get to see. And I'm sure this was kept last so that we can have everybody in and have a look at this very unusual presentation. So without any delay, let's swiftly move to Dr. Parag Sancheti and start in.
So thank you very much, Dr. Ashish and the entire faculty for joining on a Sunday. Very short, we have just started this Arthroscopy Insights group where we once a month have a webinar related to various arthroscopy topics. We've done a few in the past on osteotomies around the knee. We've done one on instability of the shoulder, one on the meniscus, and today we are doing one on the proximal humerus fractures. So this is going to be very interesting because this is a hot topic, and I've been asked to introduce this topic, and I will do that in a minute. So I hope my slides are visible. So the theme for today's Arthroscopy Insights webinar is proximal humerus fractures, dislocation, the current status. And for this, we have a very, very exciting faculty. We have Dr. Sergio all the way from Sao Paulo, Brazil. Thank you, Dr. Sergio, for joining in. We have Amit Modi from London, UK. Good afternoon, Amit. Thanks for coming in. And we have our own stars, Dr. Sujit Jos, Dr. John, Dr. Gopinath, and of course, we have two panelists, very eminent surgeons, Dr. ShreeHari and Dr. Shanavas. And of course, to take us through this entire hour or hour and a half, we have Dr. Ashish Babhulkar from my own city, who is going to moderate and chair this webinar today. On the outset, thanks to OrthoTV, and today is the World Arthritis Day. So best wishes to everybody. I think this webinar will go a long way in preventing shoulder arthritis. If we are able to understand the proximal humerus fractures right, if you're able to fix them in time, probably we would avoid the arthritis. And of course, if it does happen, we have a good solution in terms of replacement. But what is the ideal choice? I think we still don't know. The proximal fracture humerus 3-part, 4-part is definitely a controversial treatment, and we have the treatment available from fixation, which of course Dr. Gopinath will highlight. We have the hemiarthroplasty, which Amit Modi will speak, and then we have the reverse, which Ashish will speak. And I think this is important topics when to choose which one. This will also depend on the viability of the head. It has a say in the treatment. How difficult or easy was it to reduce the fracture, the stability after you reduce it, the neurovascular issues, the patient, whether he's young or old, also decides the management, also whether the bone quality is osteoporotic or not. I think the X-rays and the CT scan is something very important, and these gives us good information on the fracture morphology. And we should always have X-ray which is taken in internal rotation and adduction. Now, if not, then we don't see the GT fragment as it looks undisplaced. But actually, if you take a proper X-ray, I'm sorry, I mean, you take X-ray in good external rotation, most of the times the position of comfort is internal rotation, and you don't see the greater tuberosity. And once it's taken in maximum external rotation, you see that the tuberosity is displaced, and then one has to fix this. So I think proper viewing and identifying the fracture morphology is very important, and for this 2D and the 3D CT scans are helpful as well. So I think that is very important today to understand the fracture morphology. And if it is fixable, I think that is the way to go. and probably fixation will definitely salvage the head and see the patient through forever, unless there are some indications where we probably have to replace them. Fixation is the go-to choice, and Dr. Gopinath will tell us more. And the important thing here, and it is not as much as a avian of the hip joint, which can become very symptomatic, and the revision rates are very high when we see those, as compared to if the avian does happen in the upper limb, the non-bearing joint. I think the things are a little different. The ideal fixation time is, of course, as early as possible. We should always do that in case we are not able to reduce the head in a fracture dislocation. And there are various other ways to reduce the fracture dislocation. The important thing is to identify if at all there is a neurovascular injury. The brachial plexus can be injured, or the axillary artery as well. So one has to be careful while reducing it. And I have seen it happen that we may damage the brachial artery, the brachial plexus. Like here, it was intact. His having some pathology, whether you seeing it was impacted one. This
Yes, sir, you can start again. Unmute yourself, sir. We can't hear you.
Yeah, sorry
Yeah.
about that. So I was just speaking about, when can we do hemi, when can we do total. I think this is again important. The rotator cuff plays an important role. And there is either way you this session,
No, we can't hear you properly, sir.
the plus points. When do you choose a hemi, or when do you use can you hear now?
So, not the voice is breaking. If we can stop the video, we can check again.
I don't think we can hear Parag. Ashok, has Parag switched off? I think his internet is gone.
It's joined back, sir.
Join back, yeah.
Sir, don't on your video. Just make it.
Unmute.
Okay, can you hear me now?
We can hear you
Yes.
now. You can
Are you
share
able
your
to hear?
presentation. It's
Okay,
better.
just I think
For us.
last two slides left. I'm sorry, I'm not in my home. That's why this is the issue.
So you can share the screen, sir. Yeah.
Okay.
Right. We can hear you now.
Okay, perfect. So I think so. I was just talking about this elderly lady in reverse shoulder. I think the current status today is definitely not yet clear whether we can do a fixation, whether we can do a hemi, or we can do a total. I think the future, the further talks will tell us which way to go. We have to decide whenever it's going to be fixation, we fix it. But what I have seen generally is that the experience of that particular surgeon in arthroplasty versus trauma does bias you to a certain extent. If, like example, in Sancheti Hospital, we have a trauma team and they think they can fix all the fractures versus our arthroplasty team, which sometimes feels that replacement is the way to go. And I think in the next 1 hour or so, we will have the exact information on what is the way ahead. So without further ado, I want to thank Ashish, and I want to thank all the panelists for being there and the speakers who will take us through the further talks. So thank you very much. And Ashish, we can continue further. You're mute.
Thank you, Parag. Really appreciate. Let's have Gopi coming now to swiftly go on to talk about proximal humerus fracture dislocations and sigal options.
Click on the play button, sir, on the top. Yeah.
Ready? Can you
Yeah,
see?
that's good. That's good.
Yes. Yes.
Yeah, respected dignitaries, my dear friends and colleagues. First of all, let me thank Dr. Parag for inviting me for this presentation. I know this is a difficult topic, and we all know that often it is missed. And if you start treating them, the complication rates are so high. So if you want to reduce a dislocation, we should know in which way the fragments are displaced. And usually it is a problem which comes out with very bad results. And if you are careful, you usually get good results. And neglected cases are more dangerous than acute cases, because when you start operating neglected cases, the chance of neurological injury is very high. So if you want to reduce a dislocation, can you hear me? Which way the fragments are displaced? And
We can hear you.
Okay.
But there is a background.
Yeah, Mr. Ashok, I think the audio is repeating after a delay. It's twice.
Yes,
Audio is coming twice.
More dangerous than acute cases, because when you start operating neglected cases, voice are repeating again. So
Is this a recorded video, Gopi?
no, it is not recorded. I am live.
We can hear you.
Okay.
But there is a background.
Same thing is being repeated after a delay.
Do you have two systems playing?
It is coming twice.
No,
Do
only
you
one.
have a phone connected?
No. Voice are repeating again.
Is the
Now-
YouTube coming in from somebody's
No, it is not recorded. I am live.
Is
Can
the
I-
YouTube
can you
feed
hear now?
coming in? That will be after a delay.
Is it clear now?
Yeah, it's clear now.
Okay. So neurovascular injury is a real problem you should always look for.
Do you
Now,
have a phone connected?
No. Plain X-ray is useful in diagnosing these cases, but many of the times we may not be able to take the proper. Can you hear me now?
Yes.
Yeah. Many of the times we may not be able to take proper X-ray. So CT is a standard investigation in all these cases. And most of these patients will have, you have to look for neurovascular injury, and sometimes CT angiogram is always a good option. Now, CT is important to analyze the injury, to decide the approach, and to assess the requirement of the graft feasibility of fixation. Now, to communicate and to document, you need some sort of a classification. Robinson's classification is a good classification, and viability of the head, capsulolateral injury, difficult reduction, all these are challenges. So challenges are many, and difficulty in proper reduction and post-screw fixation, and varus collapse, AVN, all these are problems related to this difficult issue. So the management depends on the duration of the injury. Most of the time you may get in acute phase, but many cases are missed, as I told. If it is in 3 to 6 weeks, you can go for fixation. And if it is delayed, you have to think of replacement, which will be dealt by the next speaker. So fracture characteristic will finally decide whether the head will undergo AVN or not. So anterior glenohumeral dislocations, the pathology you should look for is soft tissue injuries, associated pathologies like soft tissue injuries and glenoid injuries and bone loss you have to look for. And this is one criteria will finally tell you whether the head will undergo avascular necrosis. That is a Hurtle's criteria. There are some controversies related to this criteria, but still it is a useful criteria. If it is less than 8 mm metaphyseal extension or no medial hinge and fracture through anatomical neck, this will decide whether finally the head will undergo AVN or not. So the reduction technique is very important, and sometimes you find that the head is the dislocation is there; it is not reducible. So it could be a bony fragments like a GT fragment which blocks, or it could be a soft tissue entrapment, long head of biceps or subscap tendon. And every time we should always think of vascular injury, neurovascular injury, and then heart signs and Doppler CT angiogram. This should be repeated again. It should be stressed again and again during the presentation, because this is one problem which will affect the final outcome, especially in neglected cases. So in irreducible cases, it could be a GT fragment which will prevent dislocation to be reduced, or it could be a long head of biceps which is in between the GT fragment and the head fragment. And this has to be addressed. Otherwise, you will not be able to reduce it. So close means it may not be possible, but even an open reduction, you will find it difficult. So in those situations, you have to look for what are the structures which prevents dislocation. So it could be a subscap buttonholing, it could buttonhole through the rotator interval or through the tendon itself or inferior to the subscap tendon. So these things you should be careful. So irreducible head, buttonholing through the rotator interval, the capsule and the supraspinatus and subscap tendons will constrict around the neck, and it will prevent you from reducing the head. So you can have a buttonholing through the subscap muscle itself or along at the lower border of the subscap tendon. So here the conjoint tendon acts as a tether, and most of the time you'll have to cut that conjoint tendon and reattach it, especially in those dislocations where the head is subcoracoid. So these are the things you should remember. Otherwise, you will struggle and dabble to reduce the head, and finally it results in more comminution, bone loss, and finally you end up with a bag of bone. So you should understand what is the problem which prevents you from reducing the head into the glenoid. So you can have a 3-layer block or a 4-layer block. It could be a subscap tendon which prevents dislocation. It could be a capsule, conjoint tendon. Even pec major sometimes prevent reduction of head into the glenoid cavity. You have to resect a pec major and then repair it. So subscap release, capsule release, conjoint tendon release, bicep tenotomy, tenodesis, even pec major release is sometimes needed to reduce the head into the glenoid. And once you reduce the head only, you can think of fixation. Sometimes when you open up, you can have a 3-part fracture where the lesser tuberosity is intact, and this lesser tuberosity will prevent you from visualizing the head, whether the head is anterior, subcoracoid, or into the axilla, or posteriorly dislocated. You will not see the head. In those situations, if you struggle through the fracture site and try to reduce the head, means you will produce more of comminution, more of bone loss, and then it's a problem. So what you have to do is you have to do an elective osteotomy of the lesser tuberosity, then reduce the head, and finally you convert a 3-part fracture into 4-part and fix it. As usual, these things will happen again in a different situation where lesser tuberosity and greater tuberosity are one fragment. Here also, this fragment will prevent you from visualizing the head, and you will not be able to reduce the head into the glenoid. And this fragment has to be split into 2. Again, it is an elective osteotomy of the GT and LT. And now you are converting again a 3-part fracture into 4-part fracture and reduce the head into the glenoid and think of fixation. So also you can have a small fragment which can be done by a close reduction. This is only a GT fracture. But the moment the fragment is too big, then there is a risk of fracture neck of humerus when you try to reduce this fragment. This you should be very careful. So there is a ratio which has been described in literature. AC by AB, when it's more than 0.4, the risk of neck of humerus fracture is too high. So other problems you should deal are poor screw purchase, and then you feel that the screw is being put into vacant space. Here you should be ready with the bone graft. You can use a J-wire, some technique to reduce it. We what usually is a square nail. We use a square nail, radial square nail, then bend it and then try to reduce the head from varus to the correct position. So you should have a graft ready. Now, once you reduce it, you may feel that the head is depressed. Here you have to elevate the fragment or the head, and that results in a void. So there you need a graft, whether it's a fibula graft or a iliac crust graft, you can always decide, but you should be ready to graft it. So avian, I told what is a Hertel's criteria. Metaphyseal head extension of less than 8 mm is a means there is some vascularity, and the hinge disruption more than 2 mm means avascular necrosis chances are very high. So these are the techniques where you reduce it. You have to have sutures from LT and the subscap, and then supraspinatus, infraspinatus. That should be ready before you put your plate in. And then the technique of fixation is the same as you do in a 3-part or 4-part fracture without dislocation. Now, this is one head which has been dislocated and subcoracoid, and it is almost near the axilla. And this situation you should always try to avoid. When you try to reduce the head comes out in your hand without any soft tissue attachment. This is a difficult situation to decide. Probably in a difficult situation, you should have a replacement set ready in your hand, but you should try to reduce this outcome as far as possible. But even if you do like that, if you get a situation like that, you can think of fixation. If you feel that some revascularization could occur, or you can go for a replacement. So if it's a young patient, you try to fix it. So internal fixation of the anterior glenohumeral dislocation is possible in a young person, and deltopectoral approach is usually enough, whether it is an anterior dislocation or a posterior dislocation. Now, here GT fragment is fixed just with two screws. This is not a good option, because if there is some instability or motion within GT fragment, that means that fragment will lyse off. It results in non-union, and you will get a non-union of the greater tuberosity means lack of abduction, lack of rotator function. So if you fix it, it should be a very stable fixation. And some fixation where the sutures are not taken properly and then fixation is done well, that also may fail. So taking the suture into the musculotendinous portion of the supraspinatus, infraspinatus, and subscap and tying it onto the plate is very crucial. So this is one situation where you should be ready with all gadgets to fix it. Sometimes you can put even additional screws for fixation. If you cannot fix it to the plate, or the plate is already fixed and you feel that some more sutures are needed, you can do that. So the suturing technique as well as plate fixation is very important. Whenever the head is reduced into position, you look for fixation. So you can have a surgical fixation with replacement as an option, but still this presentation is on fixation. The next few presentation will be on replacement. So if the ORAF is not possible, you can of course go for fixation. So you can have a standby replacement set ready. So type 1 dislocation, you can always go for fixation. Is a young patient. Type 2, young patients, you go for fixation, but type 2 and 3, or you think of replacement. Whether it is a RSA or a hemiarthroplasty, it can be debated in the next few presentations. So you can have a posterior dislocation. According to the defect of the head, you can think of grafting. So the approach in anterior or posterior dislocation is again the same. Deltopectoral approach, patient position is the same. You need not go posteriorly always. Here you talk about, in posterior dislocation, you talk about tenotomy of subscap, because it will prevent the visualization of the head. And when you do a tenotomy, then try to avoid anterior and inferior, because it may result in neurovascular injury. And you can think of a lesser tuberosity transfer to fill the defect on the humeral head. So young and active, you again always go for fixation in posterior dislocation as well. And then you can think of taking allograft to fill the defect on the glenoid or on the humeral head. So if you want a glenoid fixation on the posterior side, you have to go posteriorly, but usually it is not needed. Deltopectoral approach is enough for posterior dislocation also. So sometimes you can have a GT escape. For example, if the fixation is not good, the GT may escape, and finally the outcome will be very bad. So success all depends on how you suture back the GT, how the GT heals, how the cuff functions. These are the situations where you should be very careful. Now, replacement indications will be discussed in the next few presentations, and then I'll skip through the slides on replacements. So pseudoparalysis could happen even after fixation. GT escape can occur even after your hemiarthroplasty. So reverse is one option where GT is not acting, or you think that GT will fail. So hemiarthroplasty or RSA will be discussed in the next few slides. So choose your implant depending on the fracture configuration. You have to study it well. Now, in some situations, you can go for conservative measures where the patient is moribund, you cannot operate. In those cases, you can go for a conservative measures, but that is not a good option for young active patients. If you cannot give anesthesia, patient is too old, that's the situation when you select that. So the key to success are accurate imaging, careful patient selection. You have to have a biological dissection without producing more fractures, more combination, more bone loss, and you should not dabble these fractures too much, because it results in more of bone loss. And if you do that, even a replacement may fail. You may have to do a good hemiarthroplasty, but if you dabble too much and too much of bone is lost, then you cannot even do a good hemiarthroplasty or replacement. So you should be careful in a biological dissection, and then plan your fixation in such a way that you are not producing more and more iatrogenic injury. So anterior dislocation, you try to reduce. High-risk cases, you always go for a replacement if you cannot fix it in an old patient. And large GT fragment, you don't try for a close reduction. So take-home message is, if you look at the literature in detail, you do a hair-splitting discussion on literature. Actually, there is no consensus. But it all depends on the chronicity of injury, whether you're dealing with an acute injury or a chronic injury. In a chronic injury, again, you should be very careful. You should not produce a vascular injury. In an acute injury, anyway, you will look at that. In chronic injury, there will be vascular supply to the upper limb. But the moment you start dissecting, surprisingly, a vascular injury may come up. So you should be very careful to get a CT angio before doing this surgery, even in neglected cases. Thank you for patiently listening.
Thank you, Gopi. Let's have Amit Modi come in to take this one level higher and talk about the role of hemiarthroplasty in four-part fracture dislocations. My request to all the faculty is to please stick to time, because we have very limited time and we have some very juicy talks ahead. Amit, can you unshare Gopi so that Amit Modi can come in?
Any questions meanwhile, Ashish, on
Yep.
this talk, or should we take
Yep.
after?
We will take them in between as well as they come in, and the delegates can send their questions by text.
Okay, so after this talk, then we can take some questions.
Yeah, go on, Amit. Let's get going.
Hello, everyone. So, whichever time zone you are in the world, now I understand this is an arthroscopy forum, but believe me, that this hemiarthroplasty is a procedure where you can't peep through the keyhole. You will have to open the door over here. So, I've done this hemiarthroplasty talk over the years, and every time I do it, it becomes more and more difficult to actually justify this. Proximal humerus fractures, they account for about 5% of all fractures, and the third most common fracture in the elderly. Now, it's over 90 years since Codman came up with this concept of four-part fractures of the two tuberosities, the head and the shaft. And Neer took it a step further with his classification. Now, as far as you realize that this is more of a concept than a classification, I think you're okay. So even now, with all fancy classifications, hurtles and AO and everything, nobody will ever talk about outcomes of a hurtle type 11 fracture or a AO A3. We still talk of every publication is type 3, type 4. So it is something which we are very conversant. The other important thing is that 85% of proximal humerus fractures can be treated non-operatively. So it's a very small fraction that we're actually talking about, and 3 and 4-part fractures constitute only 5% of these fractures. So I'm going to deal with the why, when, and how of hemiarthroplasties. So when Neer came up with his monoblock prosthesis for fractures, the whole idea was to do it in the elderly who have poor bone because of osteoporosis, the risk of AVN high, and you want to give them a one surgery. And that's where the hemiarthroplasty concept came about. And it has been the gold standard for a very, very long time. And unfortunately or fortunately, it has been supplanted by a reverse arthroplasty now. So the indication for a hemiarthroplasty as it stands now is for the younger individuals where the fracture is non-reconstructible. So as to when you do it, you will have to have different things in your armamentarium to make your decision. You need some good imaging with CT scans. This is something which, it looks very nice as to different fracture patterns, but I don't think anybody really follows it in practice. Out of this paper, I think my previous speaker has already mentioned about the predictors of AVN. AVN is not necessarily always a disaster, okay? But when you have AVN in the presence of metalwork with a plate, then yes, it can be a disaster. So you're better off probably having AVN with a non-operative treatment than operative treatment. So this really leaves us when we are doing this. We are doing this in younger patients with a non-reconstructible fracture, and the scenarios you may be facing would be a fracture dislocation or a head split fracture or an impaction. And any of these things which can be fixed, I probably would fix it. Okay. And can we expect a good outcome in the younger individual? Yes, probably yes, because the pre-injury rotator cuff is pretty much pristine. You've got a virgin glenoid, you've got better bone stock, they've got better rehabilitation potential, and healing for tuberosities is also better. The other thing to understand is not all four-part fractures are the same. The one on the top right, a valgus type, is a very different kettle of fish, really. So these fractures can quite easily be treated with minimal intervention, with even percutaneous techniques, and with very, very satisfactory outcomes. And when you're doing a fixation, I always tend to quote my colleague who says you don't always need to aim for a gold medal. A bronze medal is good enough. If you can get a fracture in a position where you would accept it as you would for a non-operative treatment, I suppose you will get a very satisfactory outcome. Now, over the past 2 decades, there's been this raging controversy whether you do a hemi or a reverse. Okay, so as far as most people or shoulder surgeons are concerned, this is a non-controversy now. Okay, for the elderly, the treatment of choice would be a reverse for the simple reason that your outcomes are more predictable, and whether the tuberosity heals or doesn't heal, you will still have a better outcome. Whereas with a hemi, if you don't get your tuberosity to heal, you don't get your height right, it is game over, really. And the irony of all this is that majority of surgeons starting off their careers will probably be doing their first arthroplasty in a fracture scenario. And even after 25 years, I can tell you that doing a hemiarthroplasty for a fracture scenario is probably the most challenging arthroplasty you can do, really. So the literature, you can see it is filled with poor outcomes with tuberosity union following a hemiarthroplasty, varying between 37 to 73%. So even if you take a middle part figure of 50%, it is as scientific as flicking a coin, really. So half of your tuberosities will not integrate, half will, and this is not really science, really. Having said all that, I'm still very cautious of doing reverses. It is probably as non-anatomic a procedure you can do. You can look anywhere in the animal kingdom, you will not find any animal with a reverse geometry. And obviously, if the reverse geometry was so great, nature would have taken it up by itself. And to add, you have either scapular notching, acromial fractures, depending on what type of prosthesis philosophy you follow. You can have higher rates of infections and instability. Okay, so is there any way we can predict which tuberosities will heal and which will not? Now, this is backed on a recent study which we've done, looking at over 1,000 dislocations with fractures. And we have identified some certain morphology of tuberosity fracture patterns. And I'm actually doing an observational study on this at present. So sometimes you can get, especially in the younger patients, a large, big chunk like this, which you can be fairly confident that will integrate once you have done a proper hemiarthroplasty. Then you've got a second type where you have got 2 or 3 large chunks. So this is a type which may heal, may not heal. So you are sort of 50-50. And in the elderly, you get this third type where the tuberosity is absolutely mush. And you put it in the right place, you put your bone grafts, but over a few months you find that it disappears. And once the tuberosity goes, it's game over, really. So the tuberosity on the left is very different from the tuberosity on the right. Having said that, now let's come to the actual thing of how you actually do this. As I said, it is a difficult procedure because you don't have any reference to your height, your version, your offset. All these have to be worked out. And the whole idea is to restore the geometry and the most important, get the tuberosity where it actually belongs. First and foremost is prosthesis selection. I think we have come a long way from Neer's monoblock prosthesis. So every fracture prosthesis you should be using should be a fracture stem. Now, these are specially designed so that the metaphyseal area is quite hollow. So you've got ample space for your bone grafts, you've got holes for your sutures, and all of these should be platform prostheses, which means that if it ever comes to a revision, you will not need to actually take the stem out. You should be interchangeable for a reverse prosthesis. And just to give you this example over here, so this was a hemiarthroplasty which was done, which you can see the tuberosity has disappeared. You've got cement way down the canal. You've got a thin cortex. To revise this would have been a very destructive procedure. I mean, fortunately, this was a platform prosthesis, and you could convert it into reverse without being very destructive. And that's not saying that it was easy to do this. Tip number 2 is retroversion. Now, your normal retroversion, there's a big variance as to how much. I normally put my hemis in 10 to 20 degrees retroversion. And for the reason, if you excessively retrovert it, you will find that when you try to reconstruct, your posterior cuff is going to be under significant tension. And when you try to internally rotate, your posterior cuff will pull off. And once that pulls off, again, your hemiarthroplasty is going to fail very, very quickly. And the other thing is, if it ever comes to a revision, 10 to 20 degrees is what you would want to put your reverse stem in. So that serves two functions really. Step number 3 is getting the height right. And this is probably the most challenging. I mean, you have all different things. You have jigs. You can use your landmarks from the upper border of the pec major, 5.5 centimeters to the top of the dome. I don't use any of this. Okay, I use an intra-op X-ray, which is based on these two facts. One is the Gothic arch, which you see over here, and the height between the tuberosity, the cuff insertion, and the dome of the head. This is pretty constant. So if you can restore these two aspects, you will almost always get the height right. And this you do by an intraoperative X-ray. Once you have done your trial, here you've got your Gothic arch right, you've got your height right, and you will find time and again, this is an absolute idiot-proof, foolproof procedure, and I would highly recommend this. If there's one message you want to take back from this talk is this tuberosity osteosynthesis. Hemiarthroplasty for the shoulder is not a bony procedure. It is a soft tissue procedure involving balancing of your tuberosities, balancing of your cuff. If you look at your normal relationship over here, your lesser tuberosity sits way in front of the lateral fin. So the previous designs which had a lateral fins at a reference, you ended up with a very non-anatomic reconstruction with the tuberosity going all the way front, which left the anterior cuff under tension and the posterior cuff very lax. And not surprisingly, that didn't work. So most of the prostheses now have a lateral fin, and which acts as a better reference as to where you position your lesser tuberosity. How you fix your tuberosities, there are different techniques. I use the technique described by Pascal Boileau. It's got 6 sutures. The first step is attaching your tuberosity to the stem, which is the yellow sutures. And once you have done is you put all your bone grafts. So try to harvest every morsel of cancellous bone, which you pack around the proximal part of the stem. You must understand that your tuberosities are not going to stick to the metal. For your hemiarthroplasty to succeed, you need your bone to heal, and that is where your bone graft is going to come into play. Once you have done it, you close the book with tuberosity to tuberosity reconstruction, and finally you do your tuberosity to shaft with 2 further sutures. And if you get it right, you should get a pretty much watertight closure. You should be able to mobilize this patient pretty much straight away. Rehabilitation, pretty standard, 4 weeks in a sling. I commence passive forward elevation pretty much straight away. No active rotation for 3 weeks to allow some healing of the tuberosities. So what can you expect? Now, looking at this big studies, you can expect a mean elevation of about 100 degrees and reasonable rotation.
Amit,
But
you're
and
running very late. Do you want to wrap up?
okay, so I will come. So whichever way you look at it, it's a non-entity now. I think Ashish will talk more about it. Reverse is definitely the procedure of choice in the elderly, but in the younger, the hemiarthroplasty still has a role. Okay, I think Ashish, I'll conclude over there, really.
Yeah. Thank you. Thank you, Amit. Really appreciate. We can take questions for Amit while we set up the next.
Sergio, do you want to ask something?
Ashish?
Yes, go on, Sergio.
Okay, Dr. Amit, I just want to
Yes.
make a comment, okay? I just want to make a comment and a statement, okay? So the thing is, lovely lecture, but I just would like you to know that in one hand, I am a shoulder and elbow surgeon who does a lot of shoulder and elbow trauma, and in the other hand, I confess with a lot of tranquility that I, Sergio, I have given up doing hemiarthroplasty because of very poor clinical results. So it doesn't work in my hands, and it doesn't work in the vast majority of hands of my colleagues. So I'm very happy, sir, that you can do this, because as Bijayendra Singh, you know Bijayendra Singh, who lives in UK, and he says, and I agree, hemiarthroplasty for fractures is the most difficult surgery of the shoulder. He says that. I fully agree. And I just want to say something to finish. 10 years ago, I stood 1 month in Sweden with Dr. Anders Eklund. I don't know if you know him, he's very famous. And half of his work was to revise failed hemiarthroplasty to reverses. So even in wonderful hands like yours, sirs, this is a surgery with high rate of failure. Huh? So I just think that you are doing less and less and less and less in the recent years. So is this correct, sir? As time goes by, we are doing less and less and less and less. Huh?
So this is pretty much reserved for younger patients. You have a 50-year-old who has got a non-reconstructible fracture. I wouldn't consider him for a reverse. I mean, if it's a 70-year-old, it's a non-entity. I think it's not even for debate anymore, I think.
Okay, good.
We'll get there.
So
For
will it
want of
be?
time, yeah, go
So
on.
Ashish, can we just say that in the elderly patients, reverse is the way to go? But in younger patients, Amit, do you have any criteria where you would still do a reverse and not do
Still do a hemi. You
So
meant
is there
still do a
anything?
hemi.
Yeah,
I would do a hemi, yes.
in all patients, irrespective of the
But
status of the
I
cuff
have not
or
done a reverse in a young patient. I still have my reservations.
okay, okay.
You put a reverse in a 50-year-old, in 20 years, things go pear-shaped. Yeah, I mean, admittedly, you've got 90% survival even in the UK NJR of reverses at 12 years. But, what's going to happen? We don't know. I mean,
We
you
don't
could
know.
be having a pandemic of issues in
Failure.
another 5, 10 years' time, really.
Yeah, so I think Amit, Ashish's talk comes right in time to probably enlighten us of
Yes.
when not. I'm sure he will cover that in his talk. Yes,
Yeah,
Ashish, it's all yours.
sure. Thanks, Parag. What is a seminar if it doesn't give you controversy? And that's why the hemi and reverse controversy is amazing. It can keep us going, and we can keep discussing till the cows come home. But that's the way for you. I will share my insights with you because this is the Shoulder Insights webinar. And this is what I put to Chat GPT. I put in age-wise stratification. So I have two other slides for between 30 and 50 and 50 and 70, but I'll share pertinent to my talk that at 70, it said generally you would prefer a reverse shoulder arthroplasty due to poor bone quality, high failure risk, and the hemi was falling out of favor purely. We're talking about 70 plus, and I would refer to my reverse shoulder patients at 70 plus. Only consider if the RSA is contraindicated and tuberosity healing is expected. Now, that is the critical feature. How can you anticipate that tuberosity is going to heal? Amit alluded to some of his X-ray features, but I could put in a hemi and a tuberosity, and if it fails, it's not a partial outcome. It's all or none. They just go into a pseudo paralysis, and it's difficult to extricate them. This is a very interesting topic. I think the Philos plate has done a great disservice, not intentionally, but since it came before the Philos came in, we were very conservative because we didn't have a good fixation device. Since the Philos has come in, everybody thought this is the best plate for the humerus. We didn't have a good plate for humerus till then. And now, because of which, there are tons of problems. This is Mark Frankel's study. Please read this paper from La Martina. And they went back and checked in retrospect. All the surgeons showed the same X-rays, and they had a unanimous agreement in only 63%. The same surgeon, the same X-ray shown to them a few years later. And if there was an agreement, in 63% cases, the results were good. Whenever there's a disagreement, the results were poor. So this is also very interesting that to find a consensus amongst all of us is going to be tough. So what went wrong with the hemi? Is it outdated? Now, I picked up my series up to 2022. And you would see here that my number of Hemi, and this is of course not only fractures, this is fractures across to arthritis also, is representative to today's topic, that from 2010, you see this beyond this right line, the number of Hemis I have done is sharply in decline. There's a little small uptick at 2021 and 2022. It's not relevant. And it's not a random red line. The red line is in 2010 because the reverse was introduced in India. We did the first reverse at Dinanath Mangeshkar Hospital in 2010 May. And since then, the Hemis have declined. I'm upset about this. I agree the Hemi is the most difficult operation. I think it's far more difficult than reverse. And I enjoy doing the Hemi, getting all the balance and stuff. And but the results can be really, really unpredictable. To share with you my experience, this is a 63-year-old gentleman, 12 years back, table tennis player, and I did bilateral because he had a bilateral fracture dislocation. I did bilateral Hemis. He did well. He disappeared, no follow-up. Came back 12 years later with proximal migration on the right side. Left is doing still well, no pain, nothing. And after 12 years, I had to revise him into a reverse. And he still has no complaints on his left side. So there is no reason to dump the Hemi into the bin. But we have to have a lot of perspicacity. We need to be very careful on what we're doing in which patient. So the Hemi that I have done is outdated Hemi, old generation, not the modern one, still a modular one, but that process is withdrawn from the market now. Even then, we still have good revision. So we've done a revision at the age of 72, and that was not a modular, that was not a platform process. So I had to start from scratch, remove everything, put everything back again. And lucky, we still have decent movement. I've still been able to manage rotations, which is again significantly credible in these patients, because giving a revision, reverse shoulder, and still giving rotations, and that's a trick that we might share with you someday. What we should never ever do is things like this. So we tend to take proximal humerus fractures for granted, and I think there's a lot of push for proximal humerus fractures being treated by shoulder surgeons for this reason. 45-year-old diabetic lady, fracture dislocation, the one like Gopi said, some junior surgeon has done this, forgot the head is still under the coracoid. And then he calls up his senior, and senior comes down on the 5th day and comes and changes that into a generic Hemi, which is a monoblock. Still no GT there. And till that date, they've not done a single lateral X-ray. And that's one of the biggest pitfalls of shoulder surgery, that they don't do lateral. And then they've missed the greater tuberosity, which is gone behind. I was compelled to do a reverse shoulder in a patient who's just around 50 and diabetic. And there's a challenge, but there's no GT here now for me to put back in. She comes to me 3 years later. So this is when she present to me 3 years later. This is her 6-year result. And she's now a 6-year follow-up, I would say, and still doing well. But at the same time, it's such a pity that she's had 3 surgeries, and which was unnecessary completely. A fracture dislocation. Now the reverse, which is done as a revision surgery, is much worse than a reverse that is done as a primary outcome. I'm not saying she needed a reverse on day one. We should have fixed this on day one, and it was eminently fixable. But that focus, that attention, you must understand what not to do and what to do. So this is a very clear cut study, again from Mark Frankel's unit. I think one of the biggest studies of 425 proximal humerus fracture patients, and they've achieved reasonable union. But you look at the resurgery rate, nobody's looking at this. Proximal humerus fixation resurgery rates 17.5%, whereas they're down to 6.6 in a revision, in a reverse shoulder replacement. So that's a win-win for reverse shoulder, and that's one of the biggest reasons why one should pursue a reverse shoulder in these patients. So reverses in fractures are increasing, especially in the elderly patients. The GT handling, healing rates are much better. Be very sure that you're avoiding too much lateralization, as the tuberosities will be under pressure. You need to fix the lesser tuberosity and the greater tuberosity. Cannot ignore them, because not only do they give additional stability, but in addition to that, they'll give the patient better rotations as well. The stem for fractures are available in 2 mm increments, which is a little dicey, and then you end up cementing most of them as such. And please use a fracture stem to enhance the ability of the tuberosity to heal up and to get the head height or the stem height correct. But we're not even talking about height and version, which are difficult issues. And we won't discuss version today, but that's always another area of contention. So this is an 81-year-old. She's an intelligent lady. She's working. She looks after the accounts for her son's factory. And she comes up with this. It looks fixable, but she's 81. We have to understand that we cannot leverage all the factors. He has osteoporosis. She has imbalance problems, healing issues. I think this is a no contest. Now, this, I would do a primary reverse shoulder replacement. And she's a 7-year follow-up, still working with her son, still looking after his accounts. And this is how it should. So the results with primary reverse shoulders are going to be much, much more predictable, much reliable, and you're restoring function. You're not bothered about fracture. You could heal the fracture will heal well, but they will have no function with just a plating and fixation. So just trying to share with you, this is a 75-year-old gentleman, diabetic, and he's come in, no question, I would do a reverse for him. He's healed well. The guy starts driving his scooter 9 months later, has a fracture, accident. Fortunately, it's a type 2. Proximal stem is still stable. I would go and do a periprosthetic plating. I would not use screws proximally. I would not use steel wires. I've just used tapes. And I've used a cerclage tape, and that works wonders. It just heals up beautifully, and they still do well. So they still do well, provided that you can get the stem to heal and go slow on these patients. If your tuberosity has healed, and if your patient has been looked after well, and you have a good rehab program, even after this complication, they should still be able to get a decent range of movement. So that's not a problem. So more important than that is the rotation. So giving rotations in reverse shoulder is going to be challenging. Don't promise your patient. I don't. I tell them I'll restore your flexion, extension, and adduction. But for the rotation, you have to be very careful. So lastly, just sharing a couple of cases, what not to do. This is a patient from Kolkata, 75-year-old lady. You know she's osteoporotic. She's petite. She's small size. And there's a fracture there. And the surgeon decides to do some vague kind of extramedullary wire fixation. That is dangerous. It's bound to fall apart. And then he removes everything later and removes the implant and expects it to heal. It's not going to heal. And so she comes to me 8 months later, and then I have to do this. The chances of infection after K-wire, prior K-wire fixation are very high. And so I've done this for her, but that's still a pity. We could have just salvaged her and done a reverse on day one. This is a 60-year-old gentleman. I wouldn't fix this fracture in this manner. I would fix it, but do a better job. This is a day one failure, and he's the doctor, for good sake. And this is what happens. The biggest problem with proximal humerus plating is the screws that go permanent and start eroding the glenoid. Somehow I've salvaged some of the tuberosity, kept it there. How I've managed this difficult surgery as such. So most of literature is in favor. I will move through, and there's no contest here. Again, this is the ChatGPT telling us that more than 70 years, please try and do a reverse. But the complications of reverse shoulder and fractures are higher than reverse shoulder and arthritis. So the entire literature is, of course, in support when we compare the reverse versus the hemi, no doubt about that. So we shall not dwell on that. So my contention or my recommendation is patient 70 and above, aim for a reverse. And 50 to 70, be careful. I would still do a hemi, no question about that. But I need to be confident that the tuberosity will heal. I've done a good job and get. But it remains a Sisyphean task if you know what it is. So finally, in conclusion, I would say that a 2-part, 3-part fracture in proximal humerus, I would fix. The ones that are difficult, I'll keep a hemi on the backup. But the ones that are 70 and above, and you're looking at 4-part difficult fractures, I would definitely do a primary reverse on day one. Nothing wrong with that. It's much more reliable for you. So just a few seconds over 10 minutes. Thank you very much. Really appreciate this.
Yeah, thanks, Ashish. I think there was a clear message.
Dr. Ashish, can I ask you a question? What is your youngest reverse shoulder patient for trauma or otherwise?
Very interesting. I was hoping you would ask that. Why don't you load your talk
in your
while
talk,
I answer
well
your
spoken.
question?
So
We'll
just
save
to
some time
look
on
up
that.
the
So
cutoff for doing a hemi.
I don't have an age cutoff, really speaking. If it's a difficult fracture, you've got to do what you got to do. My youngest patient is a 48-year-old who's a failed hemiarthroplasty. And I have so I have about half a dozen patients who are between 46 and 55, but they are all revision surgeries. Primarily, I would not. Primarily, I would still do Hemi.
In a head split, would you
Dr.
think
Sujit,
about?
Dr. Sujit, just one thing. I have a beautiful case I can show in another presentation for sure, not today, but my youngest patient is a super mega complicated sequelae in a 38-year-old lady, 38. She was operated 7 years ago. She's 46, is the best functional result of my life. The best, 100%. And so when things got very complicated, we discussed this here with Dr. Daniel Moya in Argentina. When things get very complicated, we have to open our minds because you have very severe sequelae. You can give 15 years of peace to this patient, and then complications may happen. We have to open our minds for that with caution, but we must understand that age is not an absolute limit in very complicated cases. Just highlighting that.
Dr. ShreeHari, you have a quick comment and then we go on with the talk.
Ashish, sir, regarding rehab, is there any difference between rehab after Hemi and reverse? Do you immobilize or?
Good question. So, you know that I don't immobilize my post-op patients on front, except the hemiarthroplasty and reverses after fracture after GT and LT fixations. I'm very slow. I want the GTs to heal. So I just strap them down, go slow, just stable washes for 6 weeks. And then we start the standard program PSRP at 6 weeks. But I'm not using the same lever to mobilize these. So all hemis, all reverses, post-fracture, go very slow for 6 weeks.
Amit, what's your cutoff?
Can I just make a comment?
Ashish, can I?
Yes, John.
Your 81-year-old that lady had a valgus fracture. So even I think it was conservative management also can be tried in those patients, especially she was active, intelligent. Nowadays elderly patients with proximal humerus, not that much of a displacement. Conservative also is giving a good result. So
John,
what is your take on conservative management?
Very valid point. My actual first 4 slides were elderly patients conserved with 4-part fractures. But because I wanted to finish on time, I deleted those slides. But I conserve more 4-part fractures in elderlies than I operate, period. So, and they have the best results.
Amit, a quick comment and then we go on with the next talk.
Ashish, I found a very interesting paper actually of Johansson. It was 100, is a prospective study, 100 cases randomized between hemi and reverse. The interesting thing they found is between 70 and 80, it's a no-brainer, reverse.
Yeah.
But after the age of 80, the outcome of a reverse and hemi was no different, which is interesting. It's a 2022 paper actually.
Yeah. Interesting. But I'm sure I can speak for you. I don't have the testosterone to treat a 85-year-old lady with a hemi.
Yeah, I think that's so. Amit, what's your cutoff for doing a reverse and a hemi?
So, Ashish, Parag, there's no cutoff, as I said.
Okay.
When you say 70, it doesn't mean 70. You can have a 70-year-old who is physiologically 60. So if that is the case, I would still do a hemi. Whereas there would be a 60-year-old who is with every given medical problem, who is physiologically 75, 80. I would do a reverse in that. So I think you've got to, it's a judgment call, really.
Yeah.
I think let's move on. And we have Dr. Sujit to speak to us about arthroscopic fixation in greater tuberosity fractures.
Good evening and good morning to Dr. Sergio. Thanks, Dr. Parag and Dr. Ashish for giving this opportunity. I'll be talking on arthroscopic fixation of the greater tuberosity. So incidence, it's around 17 to 21% of proximal humerus fractures. It occurs in anterior dislocation, as well as in shear stress of rotator cuff pulling on the greater tuberosity. Left untreated, there can be limited movements due to malunions or non-unions and pain for a young patient especially. So these are the pulls we've already discussed about. The supraspinatus, the infraspinatus pulls the greater tuberosity fragment backwards and upwards. Subscap pulls the lesser tuberosity forwards. So this can be a classical split type fracture, or it can be an avulsion type due to the rotator cuff muscles contracting. The split type is due to an impaction of the posterior greater tuberosity on the anterior glenoid during a dislocation. So that's a much classification where it's an avulsion, a depression, or a split type fracture. So in avulsion, the fracture fragments are usually smaller. Depression types are inferior displaced. And the split type, the larger fragment with a vertical fracture line, which are a different ball game usually when we are thinking about arthroscopy. So when to fix 3 millimeter displacement is considered standard for an active, healthy person or an athlete, or maybe up to 5 millimeters in a general population who's less active, may not cause much functional disability as per Bono and Neer in 1970. Platzer described that up to 3 millimeters can cause functional disturbances. These are the fixation options in front of us: open reduction with a screw, a plate, a mini open reduction with canceller screws, with hook plate, mini open anchor fixations, or an arthroscopic suture bridge fixation, which we are going to discuss now. So the technique continue to evolve, especially minimally invasive techniques and arthroscopy techniques. And this is one place where the open technique has been probably given, when the arthroscopy has given better results than open fixation with a smaller incision and maybe more cosmetic and more fixation which has more tensile strength. So suture bridge gives much higher compression at the fracture interface than the screw method, which will come to with the studies we have now. So there are very few studies for the avulsion and the split types, but then these are the arthroscopy diagrams where you insert an anchor on the posterior and medial aspect where you have good cartilage, and you pull the sutures on this anchor and fix them inferiorly as well as anteriorly. This can be used for the avulsion type as well as the split type fracture, which has been described in this picture. These are the other alternatives where a mini open canceller screw fixation, which is a traditional treatment, but the problems were numerous, like subacromial impingement. The later implant removal was necessary. When you lift the arm up, it will definitely impinge on the acromion, as well as the washer and the screw giving a compression on a thin fracture fragment, which is cancellous bone, is much less than compared to sutures, which are high tension. And there is more incidence of postoperative stiffness, and pain scores are higher in studies by Yoon and Choi. And that's the Philos plating. This is, yes, definitely the strongest fixation available when you, especially when you wire the supraspinatus and infraspinatus, but you have a larger incision which is necessary. Implant removal might be necessary. You know, the blood circulation, and you got the axillary nerve coming there. That's the hook plate fixation again, which again has the problem of subacromial impingement and a larger scar. That's a study which is done by Lin and Hong, and which gives the cyclical load for displacement more than 3 millimeters is much higher in the suture bridge group, which is 262 newtons compared to 186. And these were the methods of measurement which were described by Dr. Gopi in a radiograph. That's Rolio's method, where you draw a line tangent through the shaft of humerus, and you draw a perpendicular to that, and you measure the distance of displacement from the articular cartilage and up to the uppermost part of the tuberosity, displaced tuberosity. So A plus B by B gives you the ratio. And if it's more than 0.5, it's a displaced GT fracture. That's a case example of fractured tuberosity in a 39-year-old avulsion type. Sorry, that's the MRI. Yeah. The coronal image, which shows that the cuff is intact, the subscap is okay, and the infraspinatus is affected. There's another CT scan where there is a fracture fragment, and it is it's loose. So in a CT scan, it was lying more down. But the position I used is a V-chair position, general anesthesia, the modified Elman portal, the anterolateral, the biceps working portal, and lateral working portal I used. That's the GT avulsion fracture, arthroscopically seen. You can see the fracture fragment displaced upwards, and which can be brought onto the piece. And you can see how thin the fracture fragment is. So if you try to fix this with a screw, it's obvious that it may come off, and it's like the Hemiarthroplasty debate. And those are bird beaks coming in through the tendon and you pull them out. It's quite simple. You pull them or pull these sutures from the lateral portal, viewing from intra-articular, and all of them. Then you go on the lateral side, on the lateral portal, and you fix it with the lateral nautilus anchor. There's another GT avulsion, again the same. It's quite simple and straightforward, and you get an immense amount of compression there, and it can not fail. And I never had a pull out of a anchor there. Only thing, you have to adjust the anchors in such a way that you've got at least 4 to 5 millimeters between the fracture crater and the area where you're going to compress the fracture with a lateral row nautilus anchor. And that's another case example. Yeah, so post-op rehab is almost similar to a massive cuff. I give a sling for comfort. In 3 weeks, I mean 2 to 3 weeks, we start rotations as well. All passive movements till 6, and then you thigh slides are allowed. In 6 weeks, full passive is attained, and full active range of motion is initiated at 6 weeks. The follow-up is done with VAS, constant score, and ASCS, and that's the series we had of 21 patients that we followed up. And those are the scorings which showed good outcomes at the end of a year with a minimum follow-up of 12 years. That's a cosmetic scar, full range of motion, and that's the rotations and power. That's the post-operative diagram. So advantages are, you can directly visualize the edges of the fracture. The fracture fragment almost always covers 100% of the rotator footprint in the scenarios. And bicep stenosis can very easily be done because in most of the cases, the lower part of the bicipital groove is usually fractured. So you have a bicipital pain. It's always imperative that you do a bicep stenodesis along with the GT fixation. Advantages, again, graduated compression can be given on the threads depending on the amount of pull you require. Pull-out strength is very high. Implant removal is not required. Difficulties, initial visualization can be a little difficult because if you're doing it in the first week or two, then you'll have a lot of fracture hematoma. Better to have a pump to wash it out before you start your procedure. Medial anchor placement can be carefully planned. It can be placed slightly onto the articular margin. And the lateral anchor placement might require a little bit of dissection because especially in a split type of fracture, we have to go laterally. So we had one patient who had a gap following a fixation, but fibrous union was there. 3 patients had stiffness at 3 months, but the resolve about 90% with mobilization. There was no CRPS. That's the study I could find in literature, 11 patients published in 2021. The age range was 28 to 74, and all were satisfied, even 3 patients with residual fracture displacement. So Pearl's suture bridge technique covers the fracture block with ultra-high tightened wires and disperses the shear and torsion forces all around the greater tuberosity fragment, and interconnected network of high tension threads crossing firmly fixes the bony fragment. Take-home arthroscopic reduction provides satisfactory clinical and radiological outcomes. Early post-operative passive mobilization is possible, and you use lesser implant material than other comparative methods. And this technique has lesser implant-related problems, and you don't have to do an implant removal. Thank you.
Dr. Sujit.
Yes, Dr. Sergio.
Well, lovely presentation. I just want to make a question. I have a very, very, very good experience and practice with open reduction of these cases. This is very common in my public hospital where I do shoulder and elbow trauma here. And I do exactly the same for many years, but with transosseous sutures, which work tremendously in my hands. And as I am a biceps killer, we don't have to discuss it, but I am a super biceps killer, so I do a biceps tenotomy and I put the sutures in the lesser tuberosity. There is very strong bone over there. It took me years to understand this tip, but it helps me tremendously. So having said that, but the strength, the pull of the posterior superior cuff is very strong. We know that. So having said that, I feel very confident with transosseous screws, but I would be fearful of a pull out of the anchors because of the strength of the posterior superior cuff. Having said that, have you ever had loss of fixation because pull out of the anchors? I would fear that too much, sir.
That's a very pertinent question. My concern was when I started exactly the same, because anchor placement, especially if you're using an all suture anchor. But then now what I do is I give at least 5 millimeters gap and I go onto the articular surface by 5 millimeters. I have a bony bridge there, and the all suture anchor holds well. I don't use the other anchors, the hard anchors, titanium.
How many anchors? Two anchors.
Two anchors, one anterior, one posterior, depending on the fracture fragment size.
And would you consider using, because of costs, because costs is always a problem, would you consider using metallic anchors or not?
The problem with this type of fractures is the superficial bone is not that strong. And
no, it's very weak. It's very weak.
Yeah, and you got the cancellous bone which is exposed, which is partly come off with the fracture fragment. So any anchor which goes into the cancellous bone may not have that good a purchase as an all suture anchor, which relies on the cortical or the subarticular bone. So I have good results, and I never had a pull out as such. And I would rather be more concerned about the transosseous, because when you insert a thread or a tunnel where the cancellous bone is already weak, unless you are able to catch the bone far distal from the fracture fragment, won't it have a little bit of pull-out problem? What is your experience on that? And do you do transosseous for all your cuffs as well?
You mean with transosseous sutures?
Yes.
I never had a complication. I trust this too much, and we have to understand, we all know, but the audience must understand a very important point. Greater tuberosity fractures behave like posterior superior rotator cuff tears. Okay, period. We don't have to discuss this. This is a concept. So having said that, I always pass my sutures on the tendon, never in the bone. The bone is very weak. So my sutures, they pass very below the fragment, and I use not, allow me to say, sir, a fancy construction like the beautiful ones you do. I pass one single suture on the supraspinatus, one in the infra, two sutures. I'm happy with that, but I do not allow.
Thank you, Sergio. We got your point. We're running on short of time. Sujit, thank you for finishing before time. Let's have John come in with his arthroscopic AC joint fixation, another very interesting topic and another arthroscopic topic for you. Thank you.
Yeah, just make it full screen and we can start off. Perfect.
Okay, hope I am audible and I am well seen.
Very much. Go ahead.
Good evening, everyone. Thank you, Parag and Ashish, for including me in this webinar. So my topic is on AC joint dislocations, and it again constitutes around 3 to 5% of shoulder injuries. And we all know there are 6 types, and there is no controversy in 1 and 2. And type 6, I am yet to see one. And basically, more is debatable is on type 3, 4, and 5. The commonest presentations are the 3 and the 5. So basically, my talk will be revolving around those types. So basic principle of an AC joint is if the patient is active and wants a good shoulder with a good cosmetic result, you have to reduce it, temporarily fix. You can either do by an open or an arthroscopic method. So, I am a millennium orthopedic trainee. I started in 2000. So I have seen this particular joint being, had an evolution in last 25 years. We started seeing with the open repair, large scar, metallic implant, loosening, K-wire fixations, impaired joint functions, the need of implant removal, especially when you are using a hook plate, then the chance of always a recurrence is there. Then it gradually evolved into an arthroscopic fixation. So arthroscopic fixation, also started, and it also, evolved. and started modification on that. It's one was to reduce the stress on the suture button. There was reduce the deformation of the AC joint, reduce the complication of isolated CC with the suture button. So AC was also included. Then once or both things have done, it gets to have a good stability. So I'll just show a video of one with the initial video when we started doing. This was this is the way we go in. You drill it, you pass the thread, and you take it out. And you had this particular device from the company. And when you are doing an arthroscopic ACJ, and you go at the rotating interval just above the subscap, and you started to dissect and reach the coracoid. Now, once this arthroscopic lethargy has become fragment, coracoid has no longer become a a blind spot. Now everybody is going there. So when we started long back in around 11 years back, it was little dicey to begin. This was the device we started with. This was a tightrope with a with a button. We had to pass it, and we had a retinol wire kind of a thing which was coming in. It was getting loaded, and we could see the the undersurface of the choroid, and flipping of the button under the choroid was under vision, so the chance of failure was less. So the clavicle also was seen. Then it was fixed. Then we started. This was the initial cases. Then we realized that there was an issue that of loss of production. Then we started fixing arthroscopically the AC joint also. So arthroscopically, we used to put two drills over the coracoid with keeping the scope in the subcoracoid space, two drills, and then having a crisscross, um, you know, um, passing of the fiber tape around it. You can see it nicely. Then we used to, nicely tie it up, then repair the deltopectoral fascia, the capsule, and close. So this was the initial way of doing the cases. Then we can see all these papers, which was of 2014 to 16 type, which showed that arthroscopy was a lesser morbidity, minimally approach, possibility to diagnose and treat concomitant intraarticular injuries, and no need of implant removal, which was not a must. And you can nicely visualize the coracoid. So the chance of coracoid fractures was also less because you can drill it nicely. So then the other papers, again, 2016 paper showed good vessels and minimal damage of the soft tissue. And again, 2013, we can see elegant, minimally invasive method with good results. And it again showed loss of full, and especially in type 4 and type 5, they showed that there was loss of reduction more frequently, although that there was no effect on the clinical outcome was evident. So then we had issues of, fractures of the coracoid and the clavicle. So the implant was gradually changed and started using dog bone buttons, which was a larger implant, and which used to hold the coracoid in a better fashion. And the AC and the CC ligament augmentation was again a must. And this was again showed in the papers. So we had our study, which we got the Best Paper Award in 2017 Kerala Orthopaedic Association meeting, and we had a small study from of 3 years, where one session had 5 patients, where the CC fixation was only done, and the type in the cohort 2 we had both CC and AC fixation, and we had mostly type 3, and we had few type 5. And all were operated in less than 3 weeks' time. So when we looked in, we can see, there was one patient had a loss of reduction, and but it was okay. The patient didn't have any much of a significant functional disturbance, but the failure rate was high. So that time was evaluation of AC joint. AC fixation also. So the CC fixation, we continued with the CC. And when we evaluated both, we can see that, the pre-op scores, there the time of the outcome, if you look at it, less than 1 week had a better outcome. And age was not significant, whether it's less than 30, more than 30, more than 50, we generally don't do. And there was no difference between whether male or a female. And the injury pattern also, whether it is type 3 or type 5, there was no much difference. And if you look at both the cohorts, whether in our study we had very few patients, so we didn't have much difference in both the cohorts, even though there was a higher loss of reduction, but the functional outcome was fine. We had one superficial infection. So to conclude, in that study, the time to intervention was the only significant factor, and the fixation of coraco-clavicular fixation and augmentation of the acromioclavicular joint was a very good option, since it was a small size and a short follow-up that time. So then we gradually evolved over that from arthroscopic. Nowadays, we are doing the percutaneous fixation for the last 2-3 years. So the arthroscopic fixation, we find that the diagnostic capability was the major advantage. But anatomic precision, you can see nicely the coracoid, so were chance of hitting it, and everything was perfect. There was no radiation much needed, because you had to really check the position, and the result was fine. For the percutaneous fixation, it was a very minimally invasive, faster procedure, faster recovery, only indirect visualization, and promotes for a quicker recovery. So this is the small video of a percutaneous fixation of AC joint. This is what we follow now. We generally don't do arthroscopic fixation. Again, you can see the piano key sign positive. That's the coracoid. You have to have a nice CM picture to be done. You make a small incision like over the clavicle, and you have the central part of the clavicle itself under vision, drill it, make the hole. Then you continue that hole into the coracoid using the CM picture. You go in, you have this particular fixation device. This is the one where you have a flip button, and you under the visualization, under CM.
John,
Guidance, have to be careful. Yeah.
do you want to wrap up? It's 10 minutes.
Yeah,
Come to our conclusion.
This is my so you are saying that, and we fix it that, then we go percutaneously, and percutaneously we pass the threads from front to back, and this is how we pass it, and we do the percutaneous fixation of the CC and the AC joint. So this is the final picture, and this is the 3 small wounds there, and this is the final X-ray you can see. So and for the chronic injuries, there is no doubt we have to augment it with the graft. So I think because of the lack of time, I'm not going into it. So for chronic injuries, anything more than 6 weeks, we try to augment it with the ASMET graft. The graft should be minimum of 24 millimeter at least length. So this is the evolution of AC joint fixation in my practice. Thank you.
Thank you, John. While we have Sergio come in, let's start with the questions. Amit, your call.
Ron, so I may be a bit biased with what I say, but type 3 is a very highly overtreated injury. Okay, I mean, you will have as many procedures and variations as you have shoulder surgeons. Now, we presented at EFORT in Lisbon this year a long-term follow-up of non-operative treatments, 12-year follow-up of over 100 cases with 90% patient satisfaction with non-operative measures. So, I mean, as I said, it's a very biased view over here, but our default position is non-operative treatment for the type 3s. If at 6-8 months they have symptoms, you would offer them a delayed reconstruction. And believe it, we see a lot of AC joint dislocations, and I personally do about 3 or 4 Weaver done or modifications a year. So
So,
I don't know
yeah,
what you think about
yeah.
it.
Okay. Amit, our take is that
One sec, John.
our
Sergio, you can upload your talk while John is replying to Amit's question.
yeah, Dr. Amit, our center, our average is around 5 to 7 cases of fixation of AC joint. So whenever we take a stress X-ray with holding 5 kgs of weight, and if it is more than 100% displaced, and the patient is very high demanding, most of them are cosmetically, driven also. Even we counsel them about it. So we have a very high, we don't operate on all the AC joints as you have told. Again, if the patient is, high demanding patient, especially, those who are, more worried about the cosmetic result. That's why even we have seen that in whether even if you have a loss of reduction, there is no much difference in the functional outcome. So type 3, that's what I told, it's a controversy. So my take is that if you have a stress view with more than 100% displacement, you can, think about doing it. It's not that you fix every AC joint. Mine is around 5 to 7 pieces a year.
Thank you, John. Appreciate. And Sergio, let's get going for the final talk. Very interesting.
Can I start?
Go on, Sergio. Your call.
Okay. Okay, good. So it's an honor to be here, okay? And this is a very interesting case. We will discuss a little as long as Dr. Ashish says it's possible before I show my solution. So this is the most challenging AC joint dislocation of my life. I'm Dr. Sergio from Brazil. I work in a public hospital with shoulder and elbow trauma for 21 years. So doing acute cases is very common in my practice, but nothing like this. So I presented this case 5 months ago in Patagonia Shoulder and Elbow course. And I invite you for the next edition, who's happening in the city of Calafate, Argentina, under the aegis of Dr. Daniel Moya, who is very familiar to all of us. This is just to show you that Dr. Daniel was there. He was the president of International Shoulder and Elbow Congress in 2019. And this is our good friend, Dr. Ham Yaron, who's coming to Brazil with Daniel in January for a cadaver lab that I am organizing. He's the current president of Israeli Shoulder and Elbow Society, and very good friends were there. Dr. George from Canada, president of International Congress of Shoulder and Elbow Surgery 2026 next year. And this is Dr. Guido Fierro, who was the president of Latin American Shoulder and Elbow Society until 1 month ago, and Dr. Joaquin from Mayo Clinic, president of American Shoulder and Elbow Society. So I am already inviting all of you in the name of Dr. Daniel Moya for the 2027 edition. So having said that, so all of this case started in March 2020 when this patient was 68. He has been a martial art competitive athlete all of his life, and he was working for 10 years as a professor of karate martial arts for children. He loves doing that. He had a fall in March 2020 and developed a type 5 AC joint dislocation in his left shoulder in the beginning of the chaos of the COVID pandemic, in the worst possible moment. So he was sent to my public hospital, which happened, unfortunately or fatiguely, to be the second biggest COVIDarium of Brazil. So we were not doing surgery for almost 1 year. The hospital were closed for several months, so no patient could be operated anywhere, I guess, all around the world. The hospital has had many openings, many closings, and during the first COVID wave and the second COVID wave. So the point is that after 11 months, things were a little bit better, and we were ready to operate this patient, and he was very symptomatic from an orthopedic point of view. But unfortunately, he had a heart attack few days before surgery, and he went to a cardiac catheterism. 1 stent was put in the heart, very good clinical recovery. But the cardiologist said, you have to wait 4 to 6 months after catheterism to do the surgery, the orthopedic surgery. And Then third COVID, the third wave came. And in the end of the story, first COVID wave, second heart attack, stent, wait for surgery, the third COVID. And after all, the patient stood 2 years with this catastrophe that I'm going to show you. And he was 70-year-old, extremely symptomatic, living 2 years with this. 70-year-old patient living 2 years with this in misery. He's using a mask because of COVID, of course, a grossly displaced clavicle for 2 years. And he was telling me, Dr. Sergio, the dream of my life is coming back to teach karate, martial arts. So this is very complicated. 70-year-old patient, a lot of pain, gross deformity, type 5, and he was in misery. You see the side, I always say the face of the patient demonstrate what he's feeling. He was in agony, okay? So this is the two years post-trauma APX ray. This is the 2-year post-trauma APX ray. And the question is what to do. So this patient is finished. I operated him 2 years ago. Everything is done. But I would like to know if Dr. Ashish wants to discuss. If not, I can show what I have done. Dr. Ashish, do you want to discuss or I just follow?
I think you should follow, Sergio, because we're running short of
Maybe
time, but
Ashish,
we are
just
very
one or two,
excited.
Ashish, one or
Okay.
two opinions, just very
Yeah.
quickly.
So shall we ask Sujit Jos?
Yeah, I would reconstruct it because the patient is definitely symptomatic. I will do fixation with the dog bone supports with tape and fixation of the CC, as well as the reconstruction with hamstring and fixation of the AC joint as well with the
with or without ACQ wires, Dr. Sujit, with or without?
I don't believe in the ACK wires. I use the same tapes I use for fixation of the correcoclavicular region. The same tapes I used, and they are drilled down onto the clavicle and brought up back on the acromion, and I tie them. And it works very well, better than ACK wire. Unless it comes off or fractures the acromion or clavicle, I don't use K wire.
Amit, what would you do? Just one more opinion, Amit. Unmute.
You are mute, sir.
Amit, unmute.
I would do my modification of my Weaver done. Use your coracoacromial ligament and supplement it with either vicryl tape or a fiber tape, whatever I prefer at that stage, really.
We must
So, Sergio,
understand...
I appreciate your point about the wires. So, like Sujit, I don't use the wires, but I will use the wires to hold the reduction while we finish the reconstruction. I have never used implants or the CA ligament. I've always used the semi-T, but I augment the semi-T with a ultra tape. And I use the ultra tape doubled like a loop, Sujit, and I use the knee knot. So the knee knot is a dynamic compression locking knot. So every time I do a throw, it pulls the clavicle down, and I use C-arm imaging. And the remaining, there's a long rope left back. So I'll pass definitely this one mandates CC ligament reconstruction along with AC joint passing through the acromion and back over it, because it needs a robust fixation for sure.
Yeah.
I'm not a big fan of dog button and tight rope because I see a lot of failures on the coracoid and clavicle side later on. Whatever you do, there must be a biological augmentation. But I have two special instruments here for them. Number one is the Satinsky clamp that the vascular surgeons use to pass my tape and graft underneath the coracoid. And I have a special pusher, AC joint pusher, so which is a hemispherical device, end device, which pushes, one assistant pushes the clavicle and ensures the reduction maintained while I pass the guide wire. And the tunnel, I use a single tunnel in the clavicle, and it's positioned at 35 mm from the AC joint. So it's equipoised between the conoid, which is at 45 mm, and the trapezoid, which is at 25 mm from the AC joint. So one single hole, but the drill hole has to be at 35 mm.
Yeah. So one of the points of this case, let me continue, okay? So the thing is, one of the issues in this case that we have to understand is that different from other cases, there is a soft tissue disturbance here, which is absolutely different from what we are used to see. So for me to show you what I have done, which is completely different from what I do, I have to show you what I do in my acute cases. So in my acute cases, so this is a plastic model that I have used to show you what I do. I do an incision in the long line of the clavicle, and I do 2 perforations with a 3.0 Steinmann pin. I have tried in the last 20 years 2.0, 2.5, 3.0, 3.5. The magical number, and I teach this to my residents all of the time, is 3.0. I have struggled a lot to come to this magical number. So having said that, I used children's colored shoelaces to show you what I have done, okay? So what I do in my standard cases is I use 4 number 5 AT-bone sutures passing below coracoid, passing through each one of the both tunnels, one leg to each other, and I tie them, okay? So I just tie them one by one, and I obtain 4 subcoracoid cerclages with 4 number 5 AT-bone sutures. We don't have money for fancy implants in my public hospital. We have 1.2 million patients, 1.2 million patients for a single hospital. We have to save money. We have to be very creative. So here, 1, 2, 3, 4, we see our sutures, subcoracoid cerclages. I have been doing this for 15 years so far, so good. Let me show you some examples. We must be very organized during the surgery. 1, 2, 3, 4. One example, other example, 1, 2, 3, 4. Another example, very organized. 1, 2, 3, 4. It's always the same. Another example, 1, 2, 3, 4. I do 1 to 2 cases every month. So it's important to tie all of the 4 number 5 AT-bone subcoracoid cerclages separately, okay? And completely different from, with all respect, different what have been said from Dr. Amit Modi. I do not believe in this procedure, which is the Weaver done, the transfer of the coracoacromial ligament, because it's a very, very weak structure. So this is an old photo, but I have given up doing this because I spend a lot of time and I don't see much difference in my opinion. And above, the classical fixation that I do for number 5 AT-bone sutures tied over the 2 bone tunnels. I like to use the percutaneous key wire, but when I use it, this is a big tip that I tell my residents to use a C-arm axillary view intraoperatively. It changes a lot. In blue, we see the spine of the scapula and the acromion, and in red, the clavicle. So I pass my key wire more posteriorly, and I do my perforations more anteriorly with a 3.0 Steinmann pin. So I put my perforations a little bit more anterior because I don't want the key wire to cut my AT-bone cerclages. For sure, this is a good tip. So what do I do in revision cases? So I use a semitendinosus with gracilis. I think it's important. This is the graft, and I use it passing below the coracoid and behind the clavicle as a loop around. And I tie it as a shoelace, absolutely no implants. As everybody of you gentlemen tie your shoe every day in the morning. So I tie it just as a shoelace knot above the clavicle, and I fix it with Ethilon sutures, absolutely no implants. Mononylon, Ethilon, number 3, number 2, it works tremendously to me. So having said all that, what I have done in this case, I have done something different, okay? I started with two number 5 AT-bone sutures passing through bone tunnels, okay? And only 2 and not 4 because I was afraid of a fracture in between the 2 holes because of disuse osteoporosis. Disuse osteoporosis in a 70-year-old elder, 2 years with this. So I tied. This was the first step of my surgery. 2 number 5 subcoracoid cerclages in yellow, and blue. After that, I passed 3 sutures, 3 more ethibond sutures below the coracoid and behind the clavicle as a loop around circlage, and I tied them. So then I tied behind the clavicle, represented here in orange, purple, green shoelaces. So at that moment, I had 2 number 5 ethibond subcoracoid circlages passing through the bone tunnels, the blue and yellow, and 3 number 5 ethibond subcoracoid circlages passing behind the clavicle as a loop around orange, purple, and green. But still, I used a semi-T with gracilis because, in my opinion, it was needed in such a difficult case. So I am showing in the plastic model, in the white tissue, the semitendinosus, and in this blue tissue, the gracilis in dark blue. So coming back to the plastic model, I pass it below the coracoid, behind the clavicle, gracilis and semitendinosus, and I tie it just as a shoelace, as I do in my revision cases, and I tie that with mononylon, absolutely no implants. This is my final construction. 2 number 5 ethibond subcoracoid circlages passing through bone tunnels, blue and yellow, 3 more subcoracoid number 5 ethibond passing behind the clavicle as a loop around, orange, purple, green, and semitendinosus and gracilis behind the clavicle below the coracoid as a loop around. In this case, I was sure I would have to use a key wire, not outside of the skin because we have a lot of problems, but inside of the skin. And obviously, I did a distal clavicle resection, a Mumford procedure, because it was a chronic case. So this is the patient 1 week post-op. I used the sling for 6 weeks. It's not my practice, but it was a difficult case. This is the incision 1 week post-op, and here we see the percutaneous incision for the insertion of a 2.0 key wire AC joint. This is the patient 5 months post-op. A little bit of displacement still, but the patient was absolutely happy, smiling, the pain was gone, and he was doing everything. This is the pre-op, this is the post-op, but let's see the X-rays. This is the pre-op, this is the post-op X-ray. Let's compare pre-op, post-op. Absolutely not bad. Not perfect, but not bad. But I asked for the software of the hospital to calculate the coracoclavicular distance in the software. So on the other side, the non-affected side, 13.69 millimeters. On the affected side, 16.22. So after 5 months, from a purely mathematical point of view, the coracoclavicular distance was increased at 2.5 millimeters, only 2.5 millimeters, compared to the other side, which is quite good, in my opinion, for such a challenging case. So this is the patient, 5 months post-op. This in my chamber. This is the incision, good healing. This is the percutaneous incision. This is the incision for the graft, absolutely asymptomatic, and he was doing what's best, which is smiling. And I'm gonna finish with this. In spite of UCLA scores, Mayo Clinic scores, there is only one question. Is he playing karate again? Yes or no? The question is yes. This is a very short video. He's a black belt doing absolutely everything. This is a long video I edited. It's very short. He can do whatever he wants. He was fighting, but I didn't put it because of time. I just want to show you one thing which shows the efficacy of the procedure. He's here with his children doing what he loves, but this is the end of the video. He's rolling over the shoulder. He's rolling over the shoulder. How many times he wants? 1, 2, 3, now 4. He can do it 10 times without any pain. So absolutely success. So I just thank you, all of you. It's an honor to be here. And I am Dr. Sergio Rowinski from Show the Planet from Brazil.
Thank you, Sergio. Really appreciate your case. Shanavas, you want to come in and comment? ShreeHari, do you want to comment on?
Ashish sir, I want to add up to that. How can you prevent that stretching of that ligaments post-op ACJ if you are doing a chronic ACJ? What's your thoughts? Usually, some amount of displacement will be there. What are your suggestions to?
I am sorry, I didn't understand the question. Can you ask me?
Sergio, there is plastic deformation of every structure, including the tight rope, including ligament. So we know that there's a 20% cases have their AC joint go up again, not with the full system, but a little bit like in your case. How can we prevent? What can we do to ensure that the ligament doesn't stretch out? Any tips?
In my opinion, after 20 years of practice, this is just my opinion. This is very common, happens to everybody, happens to me. So 4 to 5 weeks of an AC joint Q-wire and absolute immobility. So there is more than 100 techniques for this problem. So I learned it in med school. When there are many techniques, is because none of them works properly. But having said that, this is a joke, but very wise joke. But having said that, I was tired of losing reductions without Q-wires. So from 5 years from now, I am using again, and then I lose 2 millimeters, 3, but losing some distance, in my opinion, is very common. I guess it's almost impossible. Sometimes it becomes perfect from a radiographical point of view. Sometimes it goes up 2-3 millimeters. But from a clinical point of view, still they are fantastic. I guess you have the same experience.
Perfect.
Yeah. So thank you. Parag, you want to conclude?
Yes, I think this.
We're not hearing you.
Parag, you're going off again. Your Wi-Fi. Maybe you switch off your video, Parag, so the bandwidth will be better.
Have been thrown into.
Yeah, can I just make one comment? Had the patient been 75, not a karate player, would the lateral and clavicle excision be an option for point?
I used to do a lot of lateral and clavicle excision when I used to do the open. Once I switched to arthroscopic, I didn't want to make it more complicated. I stopped doing it. And in 15 years since I've done the arthroscopic, I've not seen any problem. So I've stopped doing the excision. But Shanavas's point was quite correct. How do you prevent? So number one, go in early. The later you go in, the more chances, and there are published reports that it will remain high. Number two, use the graft and stretch it on the graft board for 20-25 minutes till it's prepared until it's inserted. So we do the tensioning of the graft as well. And then I use a tape instead of the suture because the tape is much. So the primary fixation hold is with the tape, and then the graft will do it. I tie the graft to each other, but I pass Ethibond sutures through the tie to prevent it from undoing itself. So these 2-3 points will ensure that there is a minimum. It still means that some patients will go up, but it has reduced that incidence significantly.
One question.
Well covered, Ashish sir. That were the points I want to be highlight.
Yeah.
One question, Dr. Sergio. Why not tapes instead of the Ethibond? Because you're using 4 Ethibonds. Same cost, you'll get one long 3 mm tape. So why not use that? It'll give a better support. And I'm concerned about the coracoid because under some of the coracoid, you are passing threads. It can cut through. It's a soft bone.
Yeah. I have been hearing this. Thanks God, never happened to me. Okay, never happened to me. But you have to understand, sir, I work in a public hospital, more than 1 million patients. We here in Brazil, we are very creative because lack of money. So we prefer to have money for fillers implants and save money. So this is a concern. I'm not sure if in India you have to think about it.
It's the same.
We're the same, Sergio. We're absolutely the same. Probably worse than you. But the tape cost is similar to 5 Ethibonds. You get the same price of tape. Yeah,
it's
bargain with the company.
These implants cost hardly $150 US dollars. So I don't think it's very expensive if you compare
very expensive. Here is very expensive. Very expensive.
I think you have to import from India. It will be cheaper when you come.
There you go. Okay. Thank you, Parag. I
Yes,
suggest you switch off your video
can you hear
because
me now? I think
we can hear
this
you.
is
Yeah, we can hear
okay.
you.
So I think it was a great webinar. It's already nearly an hour overtime, but I thank all the faculties for being there, even though it is nearly 7 o'clock in India. Thanks, Amit, for joining from UK, and thanks, Sergio. That was a great case. I think a lot of learning. We could have discussed a lot more, but all good things have to come unto an end, and there'll be a recording of this available. Ashok Sham will definitely make sure that those people who could not attend, we can still attend this wonderful webinar. I want to thank all the faculties, on behalf of Ashish and myself, Dr. John, Dr. Gopinathan, Dr. Sujit, Dr. Amit, Dr. ShreeHari, Dr. Shanavas. That was really a great webinar, and we look forward to more such webinars. If you have any ideas, we'll do it. And over to Ashish to give a parting message, the last message. I'm sure Ashish will have the last word for today's webinar. Over to Ashish, and thank you once again, everybody, for joining in today. Bye-bye.
Thank you, Parag. Thank you for leading this. And we look forward to the next one. Just a very quick one-line conclusion that be very alert. Proximal humerus fractures are not the same.
Yeah.
If you're not focused or you don't have the same experience as a senior surgeon, keep a shoulder surgeon with you, and then you can hunt in pairs and you can do a better job. Definitely do an axial X-ray. If you can't get an axial X-ray, please do a CT scan from all of them. They're interarticular fractures. And that way you will never miss out. Sometimes it's an overkill, but it saves a patient a lot of grief and revision surgery, which is very common. Fixation for most, save, restore anatomy for most of them. Like Amit said, we would still do a hemi for those complex ones. Patients who are less than 50, we would endeavor not to do a reverse in these patients. But for revision patients and patients above 70, I think it's disingenuous to try and expect them to do better with fixations and hemis. You can just move on to a reverse because it's just a one-stop shop and just solve the problem and save them repeat surgery, agony, and dysfunction. And of course, AC joint is difficult. You don't need to operate all of them. We can conserve most of them, as Amit and others have suggested. And if you really need to, then you need a good technique that is reliable. But the AC joint is the hallux valgus of the shoulder. You'll have 100 procedures and no consensus. So it's still evolving. Fair enough. And thank you very much. There were a lot of learning points here. So very useful to us. Thank you for taking a Sunday out. We really appreciate that. All my faculty, all the delegates, Ashok Sham from OrthoTV. For those who missed it, tell your colleagues that you can come back to OrthoTV and go through that all over again. Thank you, guys. Love you. Have a great Sunday, whatever is remaining of it.
Thank you, everybody.
Thank you.
Thanks,
Good night.
Ashish. Thank you very much
Yes.
for your time.
Welcome.
And
Bye.
Ashok and
Bye.
Poonam, thank you very much. Bye. Bye.
Bye.
Are we offline?
Yes, sir. We are offline.
Yes, yes.